Welcome to Physician Focus. I'm Dr. Jim Kenealy. It's an axiom in the profession of medicine that physicians, nurses, and healthcare workers are at their best when others are at their worst. We saw it with the events of September 11th, Hurricane Katrina, in Haiti after the earthquakes, and most recently this April when Boston was shaken by bombings at the Marathon. Whether natural or man-made disasters, medical personnel seem always ready to react quickly, to save lives, and to care for those in harm's way. This edition of Physician Focus will examine the steps that go into preparing for such events, the kinds of training and resources that are necessary, and the impact on physicians, nurses, and other first responders. With me for our discussions are two board-certified emergency medicine physicians who are experts in disaster medicine and who are themselves first responders. Dr. Mary-Elise Manuell is the Director of Division of Disaster Medicine and Emergency Management at UMass Memorial Medical Center and Director of the Center of Excellence for Emergency Preparedness and Education and Training at UMass Medical School in Worcester. Dr. Paul Biddinger is the Chief of Division of Emergency Preparedness and the Medical Director of Emergency Department of Operations at the Massachusetts General Hospital in Boston and Chair of the Massachusetts Medical Society's Committee on Preparedness. Welcome, Mary-Elise and Paul.
Thank you.
Thank you.
You know, I personally live right in Hopkinton, down from the marathon start line. And of course, our show was taped here in Hopkinton. I think what was different about this disaster is it really struck home to us all.
Yes.
I know, Paul, you were working on Heartbreak Hill and subsequently took on your duties in the emergency room at the MGH. And I really think that if there was any silver lining to this cloud, it was really how well and orchestrated and successful our disaster response was. I know from our nurses at Metro West Medical Center who worked in the medical tent that they triaged those patients and had them cleared in about 45 minutes. There was a less than 1% mortality rate, and everyone who reached the hospital survived, which is an amazing statistic. So, Paul, what is disaster medicine? It's a little area that we all come to take for granted until we really need it.
Sure. So disaster medicine really is emergency management applied to the medical setting. Emergency management has 4 phases. It's planning, getting ready for disasters that may happen. It's mitigation, trying to limit the effects of those disasters that do happen. It's responding when called, and it's recovering, all within a medical context. It's been an evolving field over the last several decades, but really, thankfully, we can see the difference disaster medicine can make.
Mary-Elise, what sort of kind of training and preparation goes into this? Because it seems to me that's really key.
Well, there's a number of different training avenues that we have to think about, but certainly in terms of healthcare providers from the medical part of it, absolutely. Providers need to know what to expect during a disaster. And we oftentimes don't know, so you have to kind of prepare people to think on their feet and to think outside of the box. Disasters basically are when you don't have enough resources, when your needs are greater than your resources. So how do you function that way? So to train people a number of different ways, certainly lecture type trainings, but also hands-on exercises, drills, where you actually are participating. Very important to get people thinking about how they're actually going to function during a disaster.
Could you either describe some of the drills you've been involved in?
Sure. I mean, we do exercises and drills all the time, and I think it's one of the most important things of what we do. But we practice how to respond to mass casualty events, absolutely. We practice how to respond to hazardous materials events if contaminated patients come to a hospital. We practice hospital evacuation. One of the things that I think was really important in the evacuation of New York hospitals after Hurricane Sandy was that they had practiced evacuation a lot, and the fact that they were able to take more than 700 critical patients, get them out of the hospitals without a single fatality is a testament to their preparedness and a testament to the importance of exercising.
I know you spoke a little bit about the hospital training and preparedness, but what can communities do to respond, and what sort of infrastructure do we have here in Massachusetts?
Well, actually, you just made me think one of the recent exercises that took place in Central Mass was an active shooter drill, which is certainly a very active topic, and that's one where we really need to reach out to the community and other kind of interagency coordination. So we had public safety and other first responders outside of the hospital helping the hospital respond. And how do you work together? How do you communicate together? How do you plan together? An active shooter scenario is one example of that, but certainly we need to bring different agencies involved. Schools, a school system certainly needs to be involved with training and preparation and how you interface with hospitals. Many different large businesses need to be involved in that process as well.
Yeah, I think, you know, one of the key words that people are using now is the whole community approach. Everyone needs to be at the table. It's not just hospitals, certainly. It's the public safety partners, fire, police, EMS. It's public health. It's emergency management, and all the other partners, both governmental and non-governmental, that Mary-Elise mentioned. And then it's also involving the community itself. One of the things we keep seeing is that there are individuals in a community that are at extra risk, depending on what the threat is. Particularly if there's a loss of electricity or power, folks that are on durable medical equipment, such as oxygen concentrators, suction, ventilators even, are at great risk. And so identifying patients and citizens within the community who need some extra assistance or may need it, depending on what the threat is, involving them in the planning for the community, involving them sometimes in the response is really important. And so that whole community approach is what we're striving for.
I think from the coordination between the police, the fire, community, EMS, and the hospitals was really very key to the success that we saw in dealing with the tragedies of the bombings.
Absolutely.
But what can individual people do? What sort of resources like the Medical Reserve Corps or community emergency response teams, how do they function and fit into the picture so like the average person can get involved with the preparation and planning and so they can help respond?
Yeah, I think a lot of times I hear the what can I do question, both from medical and non-medical responders. And the good news is everyone has something they can do. The first thing, for what it's worth, that I would suggest is be prepared at home. The more prepared you are, the less likely you are to need assistance and to put yourself in a position to need help. Ready.gov is the federal government's website that helps people prepare. They make a home plan for how to be prepared to withstand certain types of hazards, how to recover, how to locate medicines or have extra supplies, how to help make a family plan. People are appropriately very concerned about the welfare of their loved ones when a disaster happens, and it's very hard for them to participate in the response effort until they know their family is safe. So first and foremost, I would say make a plan at home. It's one of the best things you can do. Secondly, if you're medical, there's a great program here in Massachusetts called the Medical Reserve Corps. It's a way you volunteer with your local community to be able to respond. It doesn't obligate you to respond, but you get training, you get credentialing, so that if something happens, we can make use of your talents, make use of your skills. Sometimes we have non-medical providers in the Medical Reserve Corps, but we also have things called Citizen Emergency Response Teams, CERT teams, that are very helpful as well. And that's a little bit of training, a little bit of organization, again, credentialing, usually through the local fire department or the local emergency management office. And that's the way that citizens without medical skills can also be involved and be ready to step in if they're needed by their community.
Now, I know with Hurricane Katrina, they had a lot of volunteers who showed up, and they didn't really know what they were capable of doing or what their training was. So I understand the credentialing process helps verify all that. How does that work?
So yeah, so thankfully the Medical Reserve Corps here is part of a system called Mass Response, and so if you enroll in it, they take on the obligation of credentialing you. So it's all done for you, relatively transparent, completely transparent, relatively painless, and pretty easy to do. So the credentialing happens. Spontaneous volunteerism is really hard. When someone comes and I don't know who they are, I certainly can't let them perform medically, but also it's hard to know even what tasks they're capable of. Volunteer responders that aren't requested or aren't anticipated also consume resources. Sometimes they eat the food that is meant for the responders, they need a place to sleep, they need a place to shelter, and so what we would much prefer to do is have organized groups of citizens that we can call on when we need, but also that won't end up being a part of the needs of the response rather than adding to the response.
It sounds like you're saying, first of all, don't be a victim yourself.
Absolutely.
Secondly, secure your friends and family.
Yep.
And then when you respond, don't become a burden on the system, be a help and not a hindrance.
Absolutely.
And that requires preparing ahead of time and knowing what you can do, what you can offer, and what you need to do to prepare yourself so you can be self-sufficient when you're helping.
Yet it seemed that at the marathon, the bystander response was very critical and helpful.
Yes.
Can you talk about the role of the bystander? And I think we were all very impressed because lay people, they ran towards the victims. They didn't run away from the blast. I think that's what makes people feel so proud about the Boston Strong adage. But if you could talk about the appropriate role of a bystander. Let's say you're in a situation like this, something unanticipated, something disastrous happens. What is your appropriate role as a bystander? You're not really credentialed, but you want to do the right thing.
Well, I think there's no one answer to that. I think everyone needs to kind of follow their gut and follow their instinct, because one of the things we always practice and preach is scene safety. Is it safe? Is it safe for the responder to enter that area? And we oftentimes don't know initially if it's safe or not. Certainly human nature often is you see someone who needs help and you want to help them. And I think it's the important thing to think about is that you have to each as an individual make an informed decision in terms of, am I going to help that person? What can I do? You can see that they're bleeding. You can hold pressure on the area that's bleeding. You can help them. You can comfort them. Maybe you can help them get out of danger. But I think there are a number of potentially dangerous scenarios where people have to realize that they are putting themselves in harm's way if they do respond. But a lot of people probably still will take that risk if they're able to help someone with the resources that they have.
I think that's right. I think, if you're a bystander and you want to help, certainly that's a laudable instinct, and it saved lives in the marathon, there's no question. We would like to ask people to do exactly what Mary-Elise is saying, which is just lift up your head before you go run into a scene and take a look around. The last thing we want is more patients, and there are cases where bystanders have been harmed by rushing in to something they're a little unfamiliar with. So look around, but if you're willing and able and the situation presents itself where you're needed, again, it's a wonderful human instinct, and we're thrilled that it did as well as it did. I'll encourage people to get a little bit of training. There are very simple first aid classes you can take online or with your local American Red Cross, or check in with your local fire department. There's lots of ways to get training. And it was very basic interventions, holding pressure on bleeding, putting on a tourniquet, supporting breathing and circulation, things that can be taught in only a couple of hours to any lay responder that can save a life.
I've heard much said about the tourniquets that were used and some of the lessons that came from Iraq and Afghanistan war. Maybe can you speak a little bit to how that played into both the EMS and police response, and how the tourniquets played a role?
Well, I think that the tourniquets clearly saved lives, and it's interesting that tourniquets have been saving lives since the wars in Iraq and Afghanistan started. Both, I think, when Mary-Elise and I probably did our medical training, tourniquets were out of favor. We were taught that they cost limbs, that they were damaging tissue, and it was only when we unfortunately had the experience of more improvised explosive devices we learned that was wrong, and they saved lives. I think it gets back to the first question you asked, which is, what is disaster medicine? It's the obligation to learn from previous experience, and so the fact that we've been looking at how we saved lives in the battlefield and translated that to civilian setting is really what helped. Boston EMS deserves an enormous amount of credit for teaching their paramedics and their EMTs those skills and then equipping them with tourniquets on the ambulances, something that's still relatively new in a lot of EMS systems. So from that part of the lessons learned to the hospital's lessons learned that Mary-Elise and I are responsible for, we're trying to figure out what works and doesn't work with every event that happens, and we'll change our system as soon as we can get the evidence that it's the right thing to do.
How does a tourniquet work to save lives? And if you don't have a medical tourniquet, what can you use and what can you do to improvise one?
Well, certainly the manufactured tourniquets are probably more effective than using a tie or a belt. But if you don't have a manufactured tourniquet, you use what you have. And certainly in a disaster, you often won't have resources. So any sort of device or piece of clothing or anything you can wrap around a limb, you essentially want to tie it as tight as you can until the bleeding stops. Is pretty much what you want to do. Applying a tourniquet does hurt. And so sometimes people, when they induce pain in the person, feel like they've done it wrong or that it's too tight, but you have to tighten it until the bleeding stops, and that's really kind of the key concept.
Exactly right. And again, the basic elements of first aid save lives. If you see bleeding, the most important thing we always do is direct pressure. And actually, in a lot of cases, even in the marathon, getting pressure on a wound is enough. You didn't need a tourniquet. Certainly, if it's possible, we would recommend a first responder put a barrier between themselves and the blood. There are risks of disease transmission with blood, but if you have gloves or if you can somehow put pressure on without getting blood on your hands, fantastic.
So whether like a glove or saran wrap or something like that, just to keep the blood off you.
That's exactly right. But put direct pressure on something that's bleeding, and unfortunately, there are lots of injuries that happen in day-to-day life. People having a chance to use this knowledge. And usually that works. If the direct pressure doesn't work, then in a life-threatening case where the bleeding is threatening to take the person's life, absolutely tourniquet's the right way to go. But Certainly would hate for people to run around tying off legs and arms all the time. But if direct pressure fails, then absolutely the tourniquet was the life-saving intervention.
And I think the key thing is people can bleed to death very quickly. Yeah. If it's a large artery that's been compromised, within a minute or 2-3 minutes, someone can die from bleeding. So it certainly is, you want to get the bleeding to stop one way or another, pressure and or tourniquet.
Absolutely.
One of the things that amazed me was really how quickly everyone was triaged and sent out to the various hospitals. Yeah. How did that all work? How did that coordination and communication work?
It's planning, and this was lessons learned again. You know, in Boston in particular, we have hosted events where we've had experts from Israel, from London after their bombings in the subway system, from Madrid after their bombings on the train, from Mumbai after they had an attack. And in every single one of those lessons, every single one of those events, they shared the lesson that patient distribution did not go well. Their providers and their EMS systems and others spent too long on the scene, and they sent all their patients to one hospital, and that cost lives. They shared that very candidly with us. So what we've been planning for is to avoid that mistake. We plan to get patients out of there as quickly as possible. The critical casualties were evacuated within 18 minutes, which is absolutely astounding. And they were relatively evenly distributed among the hospitals, which again is phenomenal and has never happened in the major terror incidents that we've seen around the world. So Boston EMS deserves an enormous amount of credit. The other EMS providers that were present similarly. But it's only because they learned that lesson, and it's because they practiced it. They practiced it again and again and again, because it actually goes against your instinct. If you're on scene and you've got someone who looks terribly injured right in front of you, you want to go to the closest hospital. That's why all the patients end up there. But you have to train yourself that that's not the right thing to do for each patient. You know from the data you need to spread them out. That's what they did. It was fantastic.
What were some of the unique things about the Boston situation that may have been favorable, that may not be able to reproduce elsewhere, and more importantly, what could be reproduced elsewhere?
Well, certainly there were so many medical providers right at the scene. That's, you know, the first thing that happened was you had a group of trained medical providers right there within seconds responding to the injured victims. I think the proximity of so many well-prepared facilities, healthcare facilities, and again, the training, the preparedness that went into it, but the proximity of resources, I think, was just huge luck and amazing. I mean, we were so lucky that way. We
were lucky in many, many ways. It actually happened at change of shift as well. So I had twice the amount of staff in my emergency department that I otherwise would have. And in fact, we had, at the end of the day, more resources than we needed, which was really remarkable given the events of the day. But I think just because it happened in resource-rich Boston doesn't mean that a lot of the things we did can't be done elsewhere. Patient distribution can be done in any community. Has to be done differently depending on how many hospitals are available and the distances, but it really helps. Communication is important. We've been practicing for years with our communication systems from fire, police, EMS, with the hospital, with public health. We practiced it on a regular basis. And I think it worked very well, that we had a very good understanding of how many patients there were, who was going where, what we needed to do. And so again, back to the whole community approach, I think if the communities know what each other's capabilities are, they can put together a realistic plan. Oftentimes we'll get into communities and do exercises, testing their mass casualty or testing their other plans, and you find they have invalid assumptions about what each other can do. You know, a hospital may turn to an EMS service and say, well, I expect you can give me 20 ambulances, right? And they say, we only own 5. You have to have realistic assumptions. You base your plans on those assumptions, and you'll do the best with what you have.
What type of organization oversees all that coordination and planning?
That's a good question. I think it varies community to community, region to region. Oftentimes there'll be certainly we have a state emergency management agency that oversees a lot of this. The Department of Public Health oversees a lot of this. I think individual hospitals and regions have worked together to form kind of coalitions and groups and interagency planning. It varies kind of area to area, state to state, but certainly every state has an emergency management agency, and MEMA certainly we have in Massachusetts and is one of the coordinating agencies that we have.
Yeah, you know, I talked so much about the resources we have and the good fortune we have in Massachusetts, and I'm very thankful for all of that. I think we're challenged by the fact that we have 351 cities and towns. We have a very local structure here in this state, and that's different than a lot of states that have much stronger, bigger county systems. And so when we talk about coming together as a region, it has to be more voluntary in this state. It's not quite as top-down as some states make it. And that doesn't mean it's impossible, it just means a lot more cooperation is required. So there isn't isn't necessarily actually someone at the regional level, between the local level and the state level, who's going to make people come together. But I think, you know, we've seen a lot of good movement in the last few years at regions coming together on their own, and we've seen great success because of that.
No, I think you see that in New England, even the political field, where you have, you know, very strong town governments and big towns that just don't want to transition over to a mayor, and they want their town meeting. And I think that you see that reflected and culturally, as you say, in the disaster response, the healthcare system, where it's sometimes a little bit more parochial than would meet the best interests or needs.
Well, I'm sorry to interrupt. You know, towns do a great job, and I don't mean to suggest otherwise. But some, you know, disasters don't respect town boundaries. And when 2, 3, 4, 5 towns come together, we need them to be able to work well in a response. And the vast majority of time they do. But the more they plan, the better they'll be able to do in general.
Are there any particular lessons that were learned from Boston that you think we could extrapolate to other areas?
Well, I think, again, the amount of training and exercising that was done ahead of time that clearly seemed to impact the success, I think just reiterates the importance of that. I think everyone kind of hears about a drill coming up or an exercise coming up, and it's like, oh, I don't have time for that. But clearly that really worked. That was so helpful and beneficial. So I think that's kind of one of the many major lessons learned.
Yeah, practice often, practice together, I think is absolutely one of the most important lessons. Learn from others' events, learn from others' mistakes or challenges. Certainly, again, I think we had mistakes and challenges in Boston. We're trying to identify, and we're going to try and get those out there so others can learn from our experience. No one does it perfectly, and there are always lessons to learn. But I think it also speaks to the importance of having dedicated staff, no matter what entity you work with, that are focused on emergency preparedness. Yes. Public health departments, cities and towns are all seeing their budgets cut, and it's very hard to maintain a focus on emergency preparedness.
I was going to ask you about that, particularly with the sequester and funding cuts, state and federal budget. How does that impact your ability to plan and prepare? I mean, will it not go as well next time? That's a worry.
Well, one hope is that maybe it'll bring agencies and structures together to pool our resources that will also kind of enable us to work together and coordinate efforts better by forming coalitions or groups that work together. Maybe we can kind of pool some funding and pool resources so that we can still have the resources we need in order to continue to prepare.
Yeah, exactly. I think, you know, it's unfortunate that again, health departments, hospitals, public safety agencies are losing preparedness money that they had more of 10 years ago. But the need is still there. The need is just as great. And so I think some of it has to be the recognition that you have to do it with whatever resources are available. I think politically it's important to advocate with your representatives that this is very important. We've played one football game in Boston with the marathon. It doesn't mean we stop practicing. It does not mean that any of our preparation efforts can cease. All we have to do is identify what we didn't do well enough and do them even better the next time.
You know, we have just a few minutes left, and I'd like to give both of you an opportunity to just give us some parting words or thoughts, some take-home messages. Mary-Elise.
So to reiterate one of Paul's points, just the preparedness really starts at the personal level. And if each person in their community is better prepared and has spent some time thinking about what would I do if a tornado came through and how would I respond and how could I help my neighbors in my community, just that thought process and doing a little bit of planning ahead of time will certainly help even the community as a whole.
Yeah. And I think that continues into your workplace as well, no matter what you do, whether you're medical or non-medical. Disasters absolutely happen, and people are asked to do both normal things in unusual circumstances and sometimes unusual things. And so I would guess that most people probably watching today don't know the emergency plan for their workplace. And especially healthcare providers don't know the emergency plan for their workplace. They don't know what's asked of them. They don't know how they're going to be notified. They don't know whether they should respond. And what I think they need to do is figure that out. I can almost guarantee that their institution, especially if they're in healthcare, has a good emergency plan. People have spent a lot of time on rewriting these emergency plans, testing them, validating them. But it's the individual's responsibility to find out what it is, know what's expected of him or her, and be able to respond when called. I think following those plans, helping test them, participating in exercises is how we'll make sure that we have even more resilient communities than the ones we have right now.
Well, Paul, Mary-Elise, I want to thank you both so much for being here in this program. It's been very helpful and very informative. But more important, I just want to thank you on behalf of everyone in the Commonwealth for all the work that you do, day to day, taking care of patients in the emergency setting, and also in the planning and your heroic responses, frankly, to this disaster. Again, thank you for joining us today. Best of luck in your future.
Thank you.
Thank you.
Thanks so much for having us.
Oh, it's my pleasure. For more information about disaster medicine, visit the websites listed at the end of our show. And to view past physician-focused programs covering a variety of healthcare topics, visit our website at www.physicianfocus.org. I'm Dr. Jim Kenealy, and thank you for watching.
I'm Dr. Mary-Elise Manuell.
I'm Dr. Paul Biddinger.
The bombings that occurred at the recent Boston Marathon are the latest example that disasters, whether natural or man-made, can happen at any time with little or no warning.
The response to that crisis also demonstrated how critical preparation and training are when responding to an emergency. The actions of trained medical personnel and first responders minimize death and injuries.
The bombings also showed the importance of citizen participation in assisting in emergencies, with the quick actions of marathon spectators and public tending to those wounded.
As disaster medicine specialists, we believe that it's vital that everyone learn the basics of how to prepare for disasters and what steps to take when one occurs.
To learn how you can make a plan and prepare for such incidents, visit ready.gov.
And we encourage you to volunteer as part of an emergency response team. Visit MA Responds to learn how.
I'm Dr. Michael Berry. For many medical problems, there's more than one appropriate option for testing or treatment. Determining which option to choose may be one of the most important decisions a patient will ever make. Yet too often, patients make decisions without a thorough understanding of their options. Shared decision-making can help. It allows patients and their providers to decide together based on the best scientific evidence and the patient's values and preferences. The Informed Medical Decisions Foundation has worked with a company called Health Dialogue to develop more than 30 programs on various aspects of medical care. These programs help patients work with their providers to make care decisions mindful of what patients most care about. Among our programs are those for cardiovascular disease, chronic conditions, breast cancer, mental health, end-of-life care, and screening and testing. I encourage you to learn more about how to get health care that's right for you by visiting our website.